Welcome to my channel. In this video, I'm going to talk about gallstone illeus. So let's dig in. So what is gallstone illeus? So it's a mechanical obstruction of the bowel by a large gallstone. Okay, commonly seen in elderly women. Risk factors associated with gallstone illeus is elderly, chronically inflamed gallbladder, and gallstones more than 2 centimeters. Okay, so what is the pathophysiology of gallstone illeus? So if you see the picture here, if there is a gallstone in the a, a gallstone present chronically in the gallbladder, okay, now this results in perforation of the gallbladder wall due to chronic infection or maybe inflammation. Okay, now then this results in a connection between the gallbladder and the intestine, or it may form a fistula with the colon. Okay, so when this happens, okay, when there is a fistula between the gallbladder or the intestine or the large intestine, the gallstone might move from the gallbladder into the colon, okay, so or into the small intestine. So when that happens, it may dislodge, uh, like this. It may move down into the terminal ileum. Okay, so this results in clinical symptoms like constipation, abdominal pain, abdominal distension. Okay, it presents with obstructive symptoms. So, episodic bowel obstruction. Patients may have nausea, vomiting, constipation, abdominal pain, and abdominal distension. Okay, on physical exam, there may be fever, abdominal tenderness, distension, and signs of dehydration. So, going back again to the clinical definition, it's the mechanical obstruction of the bowel by a large gallstone dislodged from the gallbladder. Commonly seen among elderly women, risk factor associated with gallstone illeus is elderly, chronically inflamed gallbladder with a gallstone more than 2 centimeters. So this results in a formation of cholecystic enteric fistula, which is a connection between the inflamed gallbladder with the bowel. Very common site is ileocecal valve and terminal ileum. Ileocecal valve and terminal ileum. Okay, so patient presents with signs and symptoms of episodic bowel obstruction. So what do you do then? You do a CT scan. Okay, you do a CT scan. You see, which is the gold standard for diagnosis, and there is something called a Riger's triad. Riger's triad is basically neomobilia, which is air in the common bile duct, okay, and a radiolucent gallstone, okay, and small bowel obstruction. How do you find the bowel obstruction? With air fluid levels. Okay, this is the air fluid level, and that's neomobilia, air in the common bile duct, and a radiolucent gallstone. Okay, so once you have those three, it stands for the Riger's triad on the CT scan. Now, gallstone illeus. Illeus is actually a misnomer. Illeus is for a non-mechanical cause of small bowel obstruction. However, this one, as we said, is a mechanical cause of obstruction due to a gallstone. Okay, so it's a misnomer. So what is the Riger's triad? It's the pneumobilia, small bowel obstruction with a gallstone. Okay, so if you see those three on the CT scan, that's the diagnosis for gallstone illeus. Sometimes, if that CT scan does not show anything, then you may go for an abdominal ultrasound. Actually, abdominal ultrasound may be more sensitive for pneumobilia and may help you identify location of the gallstones. Okay, and often HIDA is done if CT scan is not diagnostic. Okay, but a lot of times CT scan must be enough for the diagnosis of gallstone illeus. Then how do you approach medical management? So primarily, you have to fix the fistula, okay, remove the stones, and then address the intestinal obstruction, right? So the first line treatment is enterolithotomy, which is enterotomy with stone removal, okay? And then in low risk patient, you may do a cholecystectomy and also fix the fistula, all right? And other treatments involve prophylactic antibiotics. You usually start with cefoxitin for preoperative treatment, and lithotripsy is indicated for patients who are poorly surgical candidates. So that's all for gallstone illeus. Thank you.